Hi all, thank you for joining. We're going to give participants just a few more minutes to join, and then we'll get started. Hi all, thank you again for joining our webinar this afternoon. I am Miriam Khan. I am the Communications Director at Gradient Health Systems based in New York. I will just do a quick overview of what the session will look like today, then turn it over to our moderator to get us started. So again, thank you for joining. If you have any questions during the webinar, please use the Q&A feature to ask us. You can also use the chat function if you have any issues with the Q&A feature on Zoom. The webinar is being recorded. You will receive a copy in your email after the webinar has concluded. If you don't, for some reason, it is on our website, gradienthealth.org, or on our YouTube page if you search for Gradient Health Systems. Again, if you'd have any questions or want to share any feedback, you can email us at customers@gradienthealth.org. We always want to hear feedback on the session or get any suggestions on topics you want to see covered in the next webinar. I will now turn it over to our moderator, Dr. Ndava, who will take us through the outline.
Thank you so much, Mariam, for that introduction and the ground rules. Kindly confirm with me if I'm audible.
Yes, you are.
All right, thank you. Yeah, so I would like to welcome everyone on the call to this very important discussion, a very important topic, which I think by now is a familiar concept to most of us. And I also know that at one point or the other, we've all been called to provide anesthesia in a setting other than theater. It could be sedation for various procedures, and you had your own experience of challenges and things like that. So today, we actually thought of bringing this topic so that we can discuss various issues around anesthesia outside the theater environment. Please, I would like to encourage all of us to participate as much as possible through questions, an opportunity that will be provided at the end of the presentation. So today we are privileged to have two presenters that are going to lead this discussion on this important topic. So we have Dr. Kotutu Mulenga, who is an anesthetist from Zambia, practicing at the country's biggest referral or teaching hospital, who will take us through the first part of the presentation. And then later on, we will have Dr. Ramoseki Oteng, who is also an anesthetist at the University Teaching Hospital. He will come in on the second and last part of this discussion. So I would like to welcome the two presenters. So I would run through some of the discussion outline. So on this very important topic, we will run through the background or the preamble, as well as the justification of doing providing anesthesia outside the theater environment. We'll look through the indications. What are the common indications or circumstances under which you will be required or asked to provide anesthesia outside the theater setting? And then we'll zoom in on some of the risks and challenges of carrying out this type of anesthesia. This is very important because in anesthesia, we always talk about safety. And before you put up safety measures, you need to know what risks as well as challenges are for that particular procedure. Then we'll go through the standard or ideal requirements for you to be able to provide a safe anesthesia outside the routine theater environment. And then we'll discuss some of the common pharmacological options. What drug options do you have for you to actually be able to give anesthesia safely? outside the theater environment. And then we'll talk about systems. For every process, you need to discuss what are some of the systems that are important for you to be able to carry out safe anesthesia outside theater. And then we'll end our discussion by talking about some of the recommendations, especially in low resource environments where we are faced with so many challenges. So this is how the outline looks. Among other areas of discussion that may arise in the course of the presentation. So my name is Dr. Ndabasipuka. I'm an anesthetist at the Minasoco Military Hospital from Zambia. I'll be the moderator or the chair for this session. So thank you very much. And at this point, I would like to invite our first presenter, Dr. Kotutu Mlenga, to take us through the first part of the presentation. Thank you so much, Dr. Kotutu. This is your show. Thank you.
Thank you. Thank you so much, Dr. Sipoka. As I was introduced, my name is Kotutu Mlenga from the University Teaching Hospital in Zambia. So we're first going to start with a question which you answer through the poll. And this is just to get into it. So the question is, which of the following is a potential setting for anesthesia outside the operating room? So the first answer is radiology, emergency room, ICU, intensive care unit, endoscopy unit, and all of the above for the last option. So it's only one answer which we are allowed to put.
Yes, so the participants may click within the circle that is against each of these responses. Please feel free to click within the circle on each of these responses. Thank you. So Dr. Mlenga, there are a couple of responses in the chat box.
Yes.
Yeah.
Okay. So most of us, rather from the responses that I've seen here, we have all selected option E, which is all of the above. So I think we'll move on, and that is the correct answer. Anesthesia outside the operating room can happen in the radiology suite, emergency room, intensive care unit, and also endoscopy unit. So it is all the above. Administration of anesthesia outside the traditional operating room environment is referred to non-operating room anesthesia, which is NORA, which I'll be using more frequently. And it's increasingly becoming common and therefore expanding the scope of our practice in anesthesia, for us anesthesia providers. So it is a growing field. 25 to 35% of anesthesia procedures in the US are now occurring under NORA, and projections suggest that in the next decade, it will account for half of all anesthetics. So there's also been significant growth due to advances in minimally invasive.
Hello, Dr. Mlenga.
Sorry, I had some network challenges.
Okay,
I don't know
we
if
can.
I'm audible now.
Yes, please. Thank you.
Okay. So as I was saying, that it's a field which is growing 25 to 35%, and the projections are showing that in the next decade, anesthetics will account for half of anesthetics will be NORA. And there's also been an increased growth because of the advances in minimally invasive procedures, and also the shift towards ambulatory care, where we want the less invasion so that our patients can mobilize very, very early. Next slide. So like the question had, so it can potentially occur in any clinical setting, and it's common in radiology suites, such as for MRI and CT scans, especially in pediatric population or those who are very anxious or claustrophobic. Also in the emergency department for very short procedures. Endoscopy units, especially in children, and dental units, also in children mostly, and pediatrics, just for short procedures such as bone marrow aspirates. So the unusual anesthesia territories present quite a unique challenge due to the limited resources and familiar territory, and also isolation from immediate support. Therefore, safe implementation of NORA demands not only adequate resources, but also skill, knowledge, and confidence amongst anesthesia providers. Next slide. So another question for us to answer is, compared with anesthesia in the operating room, non-operating room anesthesia is associated with an increased risk, primarily due to, so the first option is higher dose of anesthetic drugs. The next option is lack of postoperative care. The third option is remote location and limited resources. The fourth option is less experienced anesthetists. And the last option is pediatric patients. So we can do the same and just take a few seconds to just vote so that we can move before. So we can pick the one that we feel is correct. Let's select an option. I don't know if I'm audible enough.
Yes, we can hear you loud and clear.
given at least one answer. Dr. Sipuka, there is a message saying submitted via the poll.
Okay.
I think I'm happy to jump in. I think maybe there's a setting that's only showing me the poll results. But it looks like most people selected answer C, remote location and limited
Answer C.
resources.
Okay, which is the correct answer. So due to the remote location and limited resources, it's what is associated with an increased risk compared to anesthesia in the operating room. Can move to the next slide. So the rationale for non-operating room anesthesia is basically to deliver anesthesia in these remote settings, which is safe, effective, and efficient for helping these medical interventions and for helping these medical interventions, which are like these small, minimally invasive procedures. So many modern interventions such as cardiac catheterization, MRI, and endoscopies are less invasive and therefore can be performed outside the theater setting just to reduce recovery time and hospital stays, as we mentioned earlier, to try and promote ambulatory care. And then also, it's a patient-centered care, which often includes high-risk groups who would benefit from this, who benefit more from this sedation rather than a full GA due to their physiological status and also to minimize physiological stress. It also enhances comfort and cooperation and also helps reduction in anxiety for these interventional procedures. Next slide. It also improves, it helps with resource efficiency and accessibility. So conducting these procedures in these specialized suites, such as in cardiology or radiology, will optimize the equipment and will also reduce the burden on operating theater, which should be reserved for either emergencies or major surgeries. And also technological and procedural advancements. It will give, first of all, us as anesthesia providers, it will help us broaden our scope of knowledge and also experience, and also contribute to the evolution of medical technology. And medical technology in these remote environments, such as TIVA with Propofol, which is now commonly being used for pediatric or adult procedures outside the OR, just to prevent a full general anesthetic. Next slide. So some of the indications for non-operating room anesthesia can either be subclassified into diagnostic procedures such as MRI, imaging, like I said, MRI, CT scan, PET scan, especially in children, or the claustrophobic or anxious or uncooperative patients. Endoscopy, such as gastrointestinal endoscopy, which is upper GI, colonoscopy, ERCP, and also bronchoscopy. Then some diagnostic procedures or interventional radiological procedures, such as angiography, which can also be a therapeutic intervention, embolization, stent replacement, radiofrequency ablation for these cardiac and vascular surgeries. So some of the interventional procedures for cardiology, like I mentioned earlier, catheterization, angioplasty, electrophysiological studies, and device implantation, such as pacemakers and defibrillators. So for oncology, such as radiotherapy in uncooperative patients, mostly these are children, and also tumor ablation. For neurosurgery and neurology, ECT, which is electroconvulsive therapy in these patients who are severely depressed. And also, like I mentioned earlier, the interventional radiology, which I earlier spoke about. Next slide. Other pediatric indications, I mentioned, apart from imaging, a lumbar puncture and bone marrow biopsies. And then also emergency or resuscitation, such as airway management, to provide urgent intervention outside the OR, that is in the ICU or in the emergency department. And also for procedures like chest tube insertion and also cardioversion. Next slide. So not very common in our setting, but can also use it for pain or palliative care when doing nerve blocks, epidural catheter injections, radiofrequency ablation for chronic pain, and then also sedation for palliative procedures such as drainage of effusions in these maybe cancer patients. And also things that do happen frequently also in our setting are wound cleaning, especially for burns, and also gynecological procedures such as manual MVAs and examination under anesthesia or in vitro fertilization. Next slide, please. So the third question is, in non-operating room anesthesia, airway emergencies are particularly hazardous because first option is patients are always intubated. Second option is access to airway may be restricted by equipment or patient position. Standard monitoring standards are lower than the OR. Anesthetists are not trained for emergencies, and patients are not staffed. So we can put answers, and then maybe Dr. Miriam, you can help me with the poll if people will still answer in the poll, if I can't see the chat.
Yes, sure. I'm happy to share. We'll give everyone a few minutes to answer.
Okay. Okay. Anything so far?
Yes, so the two most popular answers are B, followed by C. So about 70% said B, about 22% said C.
Sorry, the percentages?
70% answered option B.
Okay. All right. So option B is the correct answer because anything to do with the airway will kill you before anything else. And of course, monitoring standards are low, but then the most hazardous thing is restricted airway by equipment or by patient positioning, which I also discuss further in our risks and challenges. So some of the risks that are associated with NORA, and it's been linked that there is a higher risk of these critical incidences in NORA rather than in the operating room setting. So for our respiratory events, the ones which are most common are airway obstruction, aspiration, things like laryngospasms, desaturation, apnea, inadequate oxygenation or ventilation. So this is mostly due to the way the patient is positioned and also hard to access a patient, especially in things like an MRI suite. So it's like a hollow tube where the patient is placed, and it's difficult for you to either try and work the machinery for you to take out the patient, or even try and see how the patient is doing from inside. Therefore, it's important that you have all your monitoring on the patient. You have good oxygen supply with a backup source. You have suctioning just in case of aspiration, and you have all your drugs ready and drawn up, just like in the theater setting before you even start these cases. It's also important that you do a pre-op assessment in these patients so that at least you're able to pick out those who are at risk of certain things, like children, if they have an upper respiratory tract infection, depending on whether they need the procedure or not, you can even either postpone it or at least anticipate that this patient is a high risk and I might develop a laryngospasm, and what's my plan for it. So oversedation is also common because these are patients, sometimes they're in there already and you just want them to sleep. So you either increase the dosages or maybe you won't be patient rather, and wait for the drug to start working before you allow the patient to go for these procedures. And this oversedation can lead to cardiorespiratory depression. Therefore, it's important to have adequate dosing and appropriate drugs, and also the use of a good sedation score so that you know the target that you're looking for in your patient. So allergic reactions are also common. This is mostly contrast related. In these cases, a lot of these cases, MRI, CT scan, angiographies, mostly contrast is used, and therefore we should also just be prepared. We should make sure our crash tray is ready. We should have our emergency drugs on there, and also have an assistant to help you just to look for things and also to set up things while you're also trying to control and stabilize the patient. Radiation exposure in CT scan, therefore these are exposure for not only the patient, but also on the anesthetic provider. Therefore, lead aprons should be provided and we should make sure that we wear them. And also on certain parts that shouldn't be exposed on the patient, just such as the neck, you can put like a thyroid collar just to help them. Hemodynamic instability, these patients mostly are starved, and especially in children, they are starved, and also the elderly, mostly their physiological stress response is a little bit low. So even these drugs, we remember that they are depressants, and if we give inappropriate dosages, we might tip into hemodynamic instability, or if they are even on inhalation anesthetic inside whatever procedure they are doing. So these are patients that we should make sure we have infusion pumps ready with our vasopressors or inotropes, just so that we should be ready for any of this instability of any sort. Cardiac arrest, it's important that it's a complication and can happen. Therefore, it's important that at least even the people wherever we are, not only ourselves as anesthetic providers, but also Oh, sorry. Oh, okay, thank you. So it's also important that we must have at least people who are competent enough, or at least who can perform CPR in case of an emergency. And then also, because our patients are very far, especially in the MRI, if we don't have MRI compatible or MRI safe devices, so at least we should make sure our monitoring is intact. If we can have wireless monitoring, so that at least there's no interruption in as the patient moves in and out and things like that. And also, our emergency drugs crash tray should also be ready just in case of a cardiac arrest. If we can't, if let's say we don't have MRI safe equipment, it's best that, and we're not with the patient inside, especially in cases of the MRI and we experience a cardiac arrest, it's safer to take the patient out rather than us, the medical staff, going in there, because we're going in with everything and we may never know. It can be catastrophic if things start sticking onto the magnet. Hypothermia, especially in our radiology suites, the places are very cold, and therefore we should always make sure that our patients are actively warm. Next slide. So some of the challenges that we can see when we compare the operating room and also our non-operating room anesthesia. So for starters is the location. Just because it's not our regular niche, it's already destabilizing because it's not built for that purpose. Therefore, we have to just make sure that at least we prepare adequately, prepare both the patient and also the place. Our monitoring, sometimes it may not be as standard as the OR, but then at least we should make sure that we have our WHO recommended, which is non-invasive blood pressure, pulse oximeter, and ECG, and also capnography if we can. Then also for the equipment, our operating room, we have everything. We have suction, defibrillator, we have everything in our theaters. But then in the non-operating room setting, it's restricted because these things are probably not even found there. And also, if let's say in an MRI setting where we have to make sure that everything that we're taking in there is MRI compatible. So it's also important that we have to make sure that all these things are there, from suction, oxygen, backup cylinders, monitoring, anesthetic machine. Mostly the place is crowded, therefore you can even go there before to just try and see, to say, okay, where can I place my anesthetic machine if I have to come with one? Make sure our emergency drugs are laid out, try and acquit ourselves with the staff, and also have an assistant in any case. Our operating room staffing is also a challenge, and I've talked about it a little bit. Where in our operating room we have skilled anesthesia and surgical team, whereas the NORA setting we have basically lack of staff, and especially for staff who don't usually do all these things, it's a bit strange for them. But it's important to also just be a team player and also just help them to understand the risks so that everybody is on the same page. The environment, the OR is spacious and ergonomic. You can put in everything, you can bring in everything. Everybody knows where what is supposed to be placed. No one will come and move the anesthetic machine from here to here. But not in the NORA setting, you find they have their own equipment, they have their own things. Therefore, like I said, it's important that you just go there, try and assess the situation, see where to put your machine, see where to put your suction, your crash tray, and make sure everything is in place so that in case of anything, you're already prepared. Emergency response, in the OR, it's a team. Everybody knows what they are doing. If you need help, you can call maybe from the other theater. But then in the non-operating room setting, in case of any crisis or an emergency, there might be a delay in management. And it's also important that that at least we let the people know who are around us, to say, okay, I'm doing a NORA case on the radiology suite, or on the ICU, just in case of anything, I'll call for your help, or in the endoscopy suite, so that at least people are on alert. And if you call for them, they'll come, and there won't be much of a delay. The last challenge is the patient population. For our operating room, so in the operating room setting, elective and emergency cases, even if, unless it's maybe like a splenic rupture or something, but then there's a bit of preparation that is done prior to coming to the operating room, or a bit of optimization. However, for the NORA setting, it's a bit risky, and because these are high-risk patients and they are not very much optimized, because some of them are even coming for either the same diagnostic procedures or intervention. Therefore, some of these things can pose challenges, and it's important to do a proper pre-op assessment and try and see what you can do to try and navigate certain situations. Thank you so much. I'll hand over back to Dr. Sipoka. Thank you.
Yeah, thank you so much, Dr. Mulenga, for that wonderful presentation. It was audible and very clear. And you've really simplified the very complex issues well. So without much ado, we'll proceed to the second and last part of the presentation, after which we will open it up to questions and discussions and clarifications, etc., etc. So at this juncture, I would invite Dr. Oteng Ramoseki to take us through the second part of the presentation. Dr. Ramoseki.
Good afternoon, everyone. Thank you, Dr. Spook. I'll be taking you through the second part of the presentation. I'm Dr. Ramoseki, also studying in University Teaching Hospital in Zambia. Yes, we can go. So we'll start off with another poll. So what is the most critical pharmacological consideration when administering anesthetic outside operating theater? One, ensuring rapid recovery. Another option is maintaining precise dosing, managing potential interaction, and the last option is monitoring for respiratory depression. So we can click and also comment on the chat. Anything from our polls? I see one comment from the chat.
Yes. So the most popular answer was D, monitoring for respiratory depression, with 55% pick that answer.
Thank you, Dr. Madam. So thank you also to our participants for polling. So D is the correct answer. So all these patients, we are supposed to monitor for possible respiratory depression, as Dr. Kotutu has mentioned. I saw one answer at A, ensuring rapid recovery. So as we go through, we'll see the standards and we'll understand why we need a recovery station after a NORA. Okay. So let's look at our standard requirements for administering anesthesia outside operating room. Firstly, we need to understand that NORA itself, it presents unique challenge for us as anesthetists. So firstly, we have the human resource challenge, we have the patient-associated challenges, and also the environment. So on the human resources, we mentioned those whom are not conversant with CPR, unlike those who are working in theater. Also, there is a human resource constraint. We will find that it is being administered by non-anesthetists whom do not have training on sedation. We also tend to deal with a difficult population. This includes the frail elderly patients and also the pediatric population and those who are critically sick who cannot undergo general anesthesia. So for us to provide very safe and effective NORA, we need to acquire adequate skill and also expertise, and we do our careful planning. So we need to see all these patients. We need to have a system to assess our patients, plan for them, and also liaise with the other team, the radiologist, the whole team, so that we have a roadmap where we are going. Okay, so much attention should be paid to the specialized environment, such as radiology suites and also emergency department. For example, in MRI suites, there is an electromagnetic field that will attract ferromagnetic equipment, our earrings, our cell phones, watches. So we need to be aware of the area we are at. And when we move to the city, we need to be wearing protective gears, both for the patients, whether they're pregnant ladies, we put the gear on their abdomen, and also the anesthetists have to wear protective gear. Okay, next. Yeah. So the goals of anesthesia should be maintained for both NORA and also in the main operating room. This is to say that this patient should be planned for. For planning for a patient, you need to start with pre-operative assessment. So we take history, we examine the patient, we look at their labs, we prepare our theater, or you can come with your prepared materials from the theater, since some of the medications need to be refrigerated, and you might find that in our NORA suites we don't have those kind of refrigerations. So we have to bring your tray for emergency medicine. So precise patient monitoring and preparation. So on monitoring, we need to adhere to standard, basic standards of monitoring. So there's to say we need to connect our ECG, our pulse oximetry, and also a non-invasive BP minimum. And the provider should be able to handle all emergencies and complications that might arise. We talked about airway complications such as bronchospasm, laryngospasms. We talked about cardiac arrest and also hypothermia. So we should be in a better place, a position to manage these complications. So let's do another poll, and then we'll look at our pharmacology. So which drug is commonly used for sedation in NORA procedures due to its rapid onset and short duration? We have midazolam, propofol, fentanyl, and also ketamine. Okay. Anything from your side, Miriam?
Yes, the 50% of the participants picked B, propofol.
Yes. So we have majority of us picking propofol. So propofol is the right answer, and look at the pharmacology of other drugs. Yes, even on the chart they're picking propofol. So when you look at the standard equipment that are standard requirements, so we have equipment and supplies that should be standard. So our anesthetic machine, we should maintain regular checking. We should maintain biomet calibration and also their regular checking. And the machine that we are using should be suitable for the location. We have MRI compatible anesthetic machines and those which are not compatible. So we should be cautious of which one is where and be aware of the complication that may arise. Our crash cart should also include defibrillators and also self-inflating resuscitation bags, so that if a patient is having cardiac arrest, we can resuscitate appropriately. We should also ensure adequate supply of medications. So emergency medications, you will need your adrenaline, atropine, noradrenaline, and also anesthetic agents like propofol, ketamine, fentanyl. You also need fluids and also other essential items like airway delivery, whether nasal prongs, Gardel airway, just to assist you with resuscitation the patient. You can move. Yes. So before we do any procedure, a patient should go through a thorough evaluation. So this, you need to take a thorough medical history and also prepare them to the standard close to, or as to when they are going to operating theatre. So this patient should be thoroughly examined, and also their labs should be reviewed and be optimized if there's anything to correct on their labs. Due to the rising need for NORA and also complications associated with it, we need to get informed consent, and also for our pediatric patients, we can get assent from the guardian or parent. So here we are going to explain the risks, the benefits, and also explain the anesthesia and also alternative anesthesia that will be used for this patient. So our procedure, we are going to discuss with the whole team. That will be whether we are at interventional radiology, MRI, or CT scan, so that we have one roadmap, discuss the potential complications and how we are going to intervene or manage those complications. Next. Intra-procedural standards, anesthesia machine, we should make sure that it's also meeting the standard. It has been checked before we start the procedure, and all other equipments, they were checked before use. Standard of monitoring, we mentioned pulse oximetry, ECG, and also non-invasive blood pressure. So those are the minimum required to do any procedure under anesthesia. And we should make sure to document everything we do. The critical incidents that we experience should also be charted on our logbook. So this will enable us to audit and also plan for future gaps, for the gaps and for future training that might be needed. Okay, so for us to administer sedation and anesthesia, we need guidelines. So this can be institutionalized for every institution we are working in, or can be nationalized. But we need guidelines and the buy-in from the hospital management so that we can all practice sedation in unison. Okay. Post procedural standard, these patients need to be observed in recovery. So in recovery, we are also going to monitor our vital signs, manage the pain, manage other complications associated with the drugs or the procedure, such as nausea and vomiting. So before this patient can be discharged, other institutions, they employ criteria such as Alderet scoring criteria, but basically to include patient having stable vital signs, being able to ambulate, no pain. So scoring 9 and above on such would grant the patient to be discharged. And then follow-up care should be done to evaluate if the patient has had any complications. So for those who had prolonged sedation, they might need to be observed a longer period in our post-recovery period. So we shouldn't be hasty to discharge them. Next. So another poll, which patient population is more likely to require NORA for diagnostic or therapeutic procedures? We have healthy adults undergoing elective surgery, pediatric patients requiring image studies, and patients undergoing organ transplantation. And the last one will be patient with stable angina undergoing stress testing. Okay.
The most popular answer with almost everyone, 94%, is option B.
Yes. So pediatric population are the ones whom mostly require sedation, mainly if that MRI is a hollow tube thing, so they might be claustrophobic, they're unable to cooperate, so we need to sedate them to get good images. Okay. So now we'll move on to pharmacological approaches. So for us to give safe and adequate anesthesia, we need to understand the patient, the type of procedure, the duration of the procedure. If we are going to be having shared airway, like for endoscopy, and then also the desired level of sedation or anesthesia. So for the level of sedation, we can look at the Richmond agitation sedation scale, and we are aiming for level 0 to -2, where a patient should be calm or having light sedation. So the anesthetic provider also should understand the properties of the medication being used, their side effects, and the duration, how long will the medication last them. So whether that we are going to be using TIVA or we are going to be using gas anesthesia, inhalational anesthesia. Okay. So of note, we need to consider our anesthetic agent. Looking at the population, taking into account the duration, as we mentioned, and also the recovery profile and the potential side effects. Most of our agents that are depressive in nature, patient might have cardiac instability, might have respiratory depression. So we should be aware and also be vigilant to monitor such. Dosing and titration. So this medication should be titrated carefully to achieve the desired anesthetic level. This is to minimize the adverse effects and also the depressive effect on the CVS, the cardiovascular system. And we need to monitor for any arising complication, as we have mentioned, those respiratory and cardiovascular complications. So with our preparations, we need to have a reversal agent for our opiates. So you need to have your naloxone, you need to have your reversal for your benzodiazepines, and you also need to have emergency drugs, your resuscitation emergency drugs. I'll put them also there with a reversal agent because you need them in case you're having cardiac arrest. So your adrenaline and other resuscitative drugs that you have in your institution. Next. So pharmacological options that we have would further look at those that we commonly use. So we mentioned that propofol is the commonly used sedation and outside theater. So this one, it has a rapid onset, short duration. However, it requires careful titration as it might have respiratory depression and also hypotension on our CVS. We also have benzodiazepines, which we also use them for sedation and to alleviate anxiety. They also have the potential of causing respiratory distress and also prolonged sedation. So other options, we have opiates, mainly for those procedures that are painful like endoscopy or that are very stimulating. We might need to add an opiate to our management, but they should also be titrated and dosed according to the patient's weight because they can also give us respiratory depression, and also there's the possibility of addiction and tolerance. So we also have ketamine, which also is being commonly used, especially in the peripheries for procedural sedation. But its side effects might be associated with hallucinations and also a patient having some aggression towards the end. Next. So other options where we have anesthetic machines to deliver this agent, we have inhalational agents such as sevoflurane, especially in the pediatric population. Is good for induction and maintenance, but like I said, it will require an anesthetic machine with a volatile for sevoflurane. We also have a local infiltrate. You can use them topically or infiltrate for minor procedures such as line insertion, biopsies, and also as part of nerve blocks. But we need to be aware of local anesthetic toxicity as part of the complication and to be ready to manage it. So some of the pharmacological options that we have in our institution that we can also use, we have midazolam. Can dose it at 0.02 to 0.1 milligrams per kg initial dose. So if further sedation is required, you may repeat at 25% of the initial dose after 3 to 5 minutes, but do not exceed 2.5 milligrams per dose. And for elderly, as you mentioned, they are frail, do not exceed 1.5. Cumulatively, don't exceed 5 milligram, and for elderly, they need lower dose, don't exceed 3.5 milligram. The onset is 1 to 2 minutes and to last 30 to 60 minutes. The potential side effects, we have the respiratory depression and also hypotension on our CVS. If we have overdose, reversal for midazolam is flumazenil. The other option, we have fentanyl, which is a rapid onset short acting opioid. So we dose it at 1 to 2 mg per kg, slow IV push. So it will last for 30 to 60 minutes. But we should be aware of the potential chest wall rigidity, respiratory depression, and also apnea. Okay. So propofol, this one most of you might be familiar with its dose. So we have 0.5 to 1 milligrams per kg loading dose, and may repeat at 0.5 milligrams per kg every 3 to 5 minutes. An infusion can be started at 20 milligrams per kg per hour. Onset, we say 1 brain arm cycle, that is less than 1 minute, and duration is 3 to 10 minutes. It has a rapid onset and a rapid recovery, but also it has an anticonvulsant property. Side effects, it will cause cardiovascular and also some apneas. Ketamine, we dose at 1 to 2 milligrams IV or 3 to 5 milligrams per kg IM. Onset also, it's less than 1 minute, but it will also last 5 to 10 minutes in IV and 25 minutes in IM. The pitfalls, we talked about delirium and hallucinations towards the end or on emergence, and then patient might experience some tachycardia and hypertension. And it will cause also excessive salivation, which might need to be managed with glycopyrrolate or atropine. We also have the option of using dexmedetomidine, which can be given an IM 1 to 4 mg or intranasal 1 to 2 mg per kg, or infusion of 0.2 to 1 mg per kg per hour. The benefits of using dexmedetomidine is that it offers good sedation, but we don't experience much of the respiratory depression, and it can cause severe bradycardia and also hypotension as one of the side effects on CVS. Okay. So I think this will be the last poll. What is the critical safety measure in NORA environment? So use of non-standard anesthetic protocol, ensuring availability of emergency resuscitation equipment, limiting patient monitoring pulse oximeter only, avoiding communication with proceduralist. Yes, we can pick our answer. Okay, Mira?
Everyone picked option B.
Yes. So I think that one was a giveaway since I was emphasized multiple times in our presentation. So we need to be ready and also ensure that our emergency resuscitation equipment are there before we do any procedure. And if anything, just bring your emergency drugs with you from theater into the suite you are going. Yes, we can move to next slide. Yes. Now, looking at the principles of NORA. So we'll look at the safe systems that can be applicable to meet the standards to have to deliver a safe anesthesia and also protect our patient. So firstly, we will need a competent anesthetic provider and also a nurse or staff that is trained on basic life support. We need standard monitoring devices, and those devices in case of MRI should be compatible. So that is ECG, pulse oximeter, and non-invasive BP. So you need a reliable oxygen. So in our setting, you will find that you have oxygen concentrator, and also we have a backup in a cylinder by the side, so that if power goes, if you have a problem with your backup power, then you can switch to the cylinder. Okay, airway equipment or airway management equipment should readily be available in our crash cart. This also will include our anesthetic machine. So, and also we need protocols with well-defined escalation system to say, if this happens, how do we go about calling for help, documenting, and we can go to the extent of presenting the critical incident and auditing. So we need to complete this cycle for us to offer a safe anesthesia or sedation to patients who are coming for this sedation procedures. Next. So systems that should be put in place for us to have a working NORA in our hospitals. So firstly, we need buy-in from our leadership and governance. So our hospital superintendents and head of departments, during those meetings, they should be talking about NORA. How are we going to improve it? We should have daily allocation on the roster that, or when we have those patients scheduled, we should have someone allocated to say, if we are having MRIs for kids on Monday, we should have an anesthetist being scheduled for specifically for NORAs on that day. Okay, there should be ongoing simulations for the staff that's worked in those places, audits, so that we can improve and address our gaps. So policies and protocols should be defined, and consent we talked about, and escalating pathways. So secondly, we need to make sure that our drugs and emergency kits they are available. So we need to have a standard sedative plan, and our standard induction drugs should be available. Emergency drugs, we talked of epinephrine or adrenaline, atropine, and reversals such as naloxone or flumazenil. We need to have IV fluids, and we need to have a documentation system where we start off by booking patients. So we have to have our booking book, our recording logbook, documentation on patient's file, and also our auditing guidelines to say, after every month we audit what we have done, and we see where to address our gaps. Next. So before every patient goes under sedation or any anesthesia, we need to apply our hook surgical checklist. This is to safeguard the patient and also make sure that we are doing the right procedure. So signing in, timeout, and signing out should be done. Okay, so we should have a brief and structured handover between those who are doing procedures, the anesthetist, and the nurses in recovery. There should be a smooth handing over of all the relevant information. Precautions should be taken against infection and also radiation. So this patient should be protected. So all surgeons should wear or anesthetists and proceduralists should wear protective clothing, observe adequate or appropriate hygiene. And for radiology and fluoroscopy, lead aprons and thyroid shields should be worn both by the staff and also pregnant ladies and other patients who are at risk. Next slide. Basic airway equipment. Our crash cart or airway trolley should have both pediatric and adult. So we should have a range of sizes for both face mask, oropharyngeal airways, ET tubes. Our laryngoscope should be checked every day, so that we make sure that the batteries are not flat, the blades are working, there's adequate illumination at the end. We have a self-inflating back valve mask, and our suction, whether we have a wall suction or a small machine or foot suction, but there should be a suction inside the suit and also in recovery. So standard of monitoring, we talked about the minimal accepted monitoring requirement, and then we can also add capnography. So in instances of MRI, the sampling tube will be taped at the or by the corner of the mouth. Then it will give us the capnometry. And the other thing that we need to monitor is temperature, as Dr. Kotutu mentioned, possibility of hypothermia in the cold suits that we have in radiology. Next. So when you look at our infrastructure and staffing, so we should have a reliable source of oxygen. So piped oxygen or cylinder, preferably we should have two sources, a cylinder and a concentrate, or a cylinder and a piped line. You should have a working powerful suction, adequate illumination, and also there should be emergency access to the patient. So you should be conversant with how to operate or stop the MRI machine, pull the patient out. The controls you should be taken through how to operate those machines. And then for staffing, we talked about ongoing simulations for capacity building in our staffs that are assisting us or working with us in NORA places. They need to be competent in those procedures. Yes, I think. So when summarizing our safe system in NORA, we need to complete a checklist. So before we start, we need to identify the patient, make sure that the procedure that is done on the patient correspond on the labeling on the consent form. Patient has fasted and there are no allergies documented. So this will be our standard signing in, and also the standard consent form will have those information about fasting and allergies. So a responsible anesthetic provider should present, and we have an agreed plan with the whole team. And basic monitoring that we need should be connected and make sure that it's working before the procedure starts. Oxygen source should be checked, suction should be checked, and our airway trolley, we should align the sizes that are required for that patient at that time, so that we have easy access to know that for a pediatric, that we calculate the ETT size. We put 3 sizes, one above, one below, airway, the mask, supraglottic airway, and the blade. Okay, so emergency drugs should be diluted, and if possible, the right doses also be calculated for the patient that is being attended at the time. So we need also to take safety precautions, wear our PPE, radiation shields if applicable. And then at the end of the procedure, we need to perform timeout, confirm the site, and then plan for extubation or the sedation. Then we transfer the patient to recovery room. Next. So when you look at the recommendations, so it's recommended that we have a trained anesthetic provider present during these procedures. We have at least a working pulse oximeter for every patient. So this pulse oximeter should be monitored continuously, not periodically. So you should have oxygen source with also backup. Make sure that we have suctioning. As we mentioned that some of the drugs like ketamine will give you those secretions. Emergency kit with clear labeling should be available. And then we should also adopt the WHO checklist. Make sure that our airway trolley has sufficient equipment that we mentioned. Okay. So additional recommendation, we talked about capnography on sedated or ventilated patient, because we'll also monitor if patient has cardiac arrest. We'll see from disappearing of our capnography. We need continuous BP monitoring and also ECG for those patients with deep sedation. And also we need local simulation and training for airway emergencies. Full anesthetic machine or transport ventilator should be on standby, so that if any patient have a airway complication or respiratory depression, we can convert from sedation to GA. And then a formal team to govern or guide the NORA should be appointed. So we should have champions for NORA. Next slide. So these are the implementation tips that we can employ or start with, so that we have a working system when we do our NORA. So we need to have our monitoring. Let's start with a working pulse oximeter that will have will cover every case that we do in NORA. We adopt surgical WHO checklist. We can also modify it to suit our local environment. Ensure that we have oxygen and power backup, and also centralize your logbook. This will enable us to note the adverse effects for auditing, and also equipment and drug monitoring and checking to see how much are we consuming, how much should we restock our supplies, and it also helps the management to plan and also do their budget. So we should also plan for NORA training, supervision, or supervision within the anesthetic department. Okay. Next slide. Yes. So at this juncture, we'll hand back to the moderator, Dr. Spuga.
Yeah, thank you so much, Dr. Ramoseki, for that, I think, brilliant presentation. I think on behalf of the participant, we can attest to the fact that this presentation is quite loaded and quite exhaustive of this topic. And thank you so much for simplifying the concepts that would have been very difficult for us to understand. Thank you so much, Dr. Kotutu, also for a well-presented discussion. So at this point, we'll go straight into questions, clarifications, or anything, any comments that anybody may have. I know there's been some questions in the chat box that some of them have been partially been addressed, but should there be need for more clarity, please feel free to raise your hand and unmute your microphone, and please ask your question. While we're waiting for, and in case we don't recognize you, we don't see your hand up early, please feel free to unmute your microphone and make your comment. So as we are waiting for any further comments or questions from the participants, I would like to find out from my colleagues. We have Dr. Sweetbet and Dr. Papicho on the call. If you have any comments, additional comments to make to this presentation, please feel free to unmute and make your comment. Yeah, so as we await for comments from the audience, I'll just quickly pick up some comments from the chat box. Jonas Msegi is requesting if there's any WhatsApp group within this network where he could join. I think we'll take note of this and see which appropriate WhatsApp group. I think we have several WhatsApp groups that have been created for the anesthesia networks. And so we'll surely add your number. Please just send us your line if you have it just within the chat box, then we can pick it and add it to one of the groups. Thank you. Yes, Dr. Papicho, please go ahead. Yes.
First of all, I want to thank you, our participants, for being there during this presentation, and thank you to the presenters for the wonderful job. This is a very important topic. Looking at what happens in our institution, we have that responsibility of taking care of this patient that comes from different.
Dr. Papicho, your microphone is not so clear.
Is it better?
Yes. Thank you.
Okay, sure. Yeah, I was a bit far from the phone. So I was saying thank you to our participants for being there throughout, and thank you to the presenters for this wonderful job. This is just to emphasize on our responsibilities when we go out there taking care of this patient doing NORA. Our responsibilities start from the time when we get in touch with the patient until when patient is taken back to the ward where he belongs to. Usually what happens in the ward where we take the patient, they don't have that capacity or capability of recovering this patient. And many patients complicate after we've surrendered them to the relevant department where they come from. These patients, when they are sent for these investigations, some are different, some are simple investigations, some are quite invasive procedures that are being done on them, so they need close monitoring. Monitoring is a key in the success of these procedures that we do outside there. Otherwise, it was a very good presentation. Thank you.
Thank you so much, Dr. Papicho, for that valuable comment. We really appreciate it. As we wind up, seeing we've been on the call for over an hour, I'll just look through to see if there's any hands that has been raised. And please feel free, just in case we don't recognize your hand early, feel free to unmute and go ahead and make a contribution as we wind up. I also want to recognize the numbers that have been sent in the chat box. I think we've saved these lines and we'll add you to appropriate networking groups for the anesthesia providers. Thank you so much for sharing your contacts. Yeah, so once again, as we wind up, just looking in the chat box now, we have a comment from from Ukeni, Njame says, wonderful presentation. Please create a forum for us to add for us or add us to whichever forum is available. Such discussions are always informative, especially for some of us still in anesthesia training. Yeah, thank you so much. We'll definitely action this request. Yeah, so I see no hand raised and no further comments or questions at this particular point. I just want to thank the presenters as well as everyone who managed to join the platform. Thank you so much. We really appreciate, and I hope you learned something from this presentation. Thank you, and I'll hand it over to Magdalena from Gradient just to give us some closing remarks. Thank you so much.
Thank you so much, Dr. Mulega and Dr. Ramoteki for the presentation. Thank you so much for our attendees. We would like to thank you so much and also let you know that in case you need anything and to learn more about Gradient and its products, please feel free to visit our website, www.gradienthealth. And then we do offer anesthesia machines and also ventilators. And also we look out for also some webinars that are coming up. We also do some product-based webinars. So if you want to know more about our products, we link them together with anesthesia practice. So look out for those advertisements and also more on clinical webinars like these ones. And thank you so much for your participation. Also, it was quite a wonderful webinar session. Thank you and see you again, and look out for the recording. Bye.
Bye-bye. Thank you.